Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. On November 10th and 11th, a number of ICOS friends and colleagues attended the American Heart Association in Philadelphia, Pennsylvania. And there we had an opportunity to speak with them about how the AHA was addressing cardio-oncology at the meeting this year. There might be some background noise in these episodes because we're recording live in the hall, but other than that, I know you're going to enjoy these episodes, so thanks for joining us.
Hey everyone, this is Abdelrahman Ali, a Cardio-Oncology Fellow from MD Anderson. We're here live at AHA Scientific Session. We're recording a podcast for ICOS and have the pleasure today of having Dr. Eric Yang, Director of Cardio-Oncology Department at UCLA. And I also have Dr. Daniel Addison, Director of Cardio-Oncology at Ohio State. I also have the pleasure of having Dr. Danielle Lenahan. We will be talking about biomarkers in cardiotoxicity, one of the sessions that was presented today at AHA.
Thank you, Dr. Lee, for having us. I think it's it's been a marathon of a meeting in a good way. Again, really kudos to the AHA Cardio-Oncology Committee for really advocating for a lot of great science and review of all the advances, but still obviously also highlighting a lot of the gaps of knowledge that we need to overcome in order to make our understanding and provide our cardiovascular patients and cardio-oncology patients, colleagues, better roadmap on how to navigate risk stratification of cardiotoxicity. But it's been a great day, only day one so far.
So Eric, I understand you are the social media director for this session. So, did you come up with a game plan, or was this clearly a think on your feet sort of thing?
It was a bit of both. I think, this is why, frankly, I look so tired right now because I'm still recovering from that. But, I think really, the American Heart Association, to their credit, really, I think, is trying to broadcast findings from this scientific sessions on a much more international scale, if you think about it, right, with X and other social media platforms. So my goal was really to, again, especially for the attendees who can't make it, as well as people who want to comment on some of the live science, to really provide a quick, high-yield bullet point, discussion of all the speakers we had for the hour. And as you know, I cover the section leveraging biomarkers for cardio-oncology. And there's a lot of exciting work, but also a lot of unknowns. And we really, had just a fantastic ensemble of experts going over, what we know, but also what we still need to know in the field. So really exciting hour.
Super. And Daniel, what were your observations from that whole session?
I think I can only but add a supportive language to what Dr. Yang has already alluded to. So in many ways, I think that session was kind of an opportunity to really cover some of the various real disciplines in terms of imaging as it relates to cardio-oncology. We had both a myriad of representation in terms of expertise, from nuclear medicine to MRI to echo to CT to PET, and really we covered or tried to cover really the contemporary state of imaging within the space of cardio-oncology. And I think this really provided a unique opportunity to really kind of marry both the imaging and cardio-oncology committees / councils, and really a space that's needed within our field on a daily basis.
Dr. Yang, would you be able to talk to us a bit more about maybe novel biomarkers that were discussed today, things that the audience might be interested in to look up for in the future?
Yeah, and so, I think a lot of us have some preconceptions on what biomarkers are, and I think, just to kind of give some exposition again, I think really one of the most difficult aspects of our field is really trying to kind of dispel the stereotype we have in our head that cancer, disease, and cardiotoxicity, it's not a panacea. And I think that, despite all the, the developments and advances we've had in advanced multimodality imaging, as well as our understanding of biomarkers, we continue to see, unfortunately, a lot of inconsistent data on what is predictive of cardiotoxicity in a variety of cancer, disease, and treatment regimens. So I think, really, again, I think, well, first of all, for instance, commenting on, for instance, Dr. Palaska's first talk, where he talked about in the setting of immune checkpoint cardiotoxicity, right? I mean, that is really one of the most dramatic, potentially fatal disease states that, while rare, it's not something we want to miss. And yet we are still, it still requires, a really collection of both serum and imaging biomarkers that have limited degrees of sensitivity. And we really need to really, understand the disease process more. But we are slowly making headway into discovering more about, understanding this. And we kind of have to, because, as you know, over 40% of the U.S., cancer population will qualify for immune checkpoint. And the absolute number of immune-related adverse events are going to increase. And we have to really, as a field, not just cardio-oncology, be aware of and anticipate, the short and long-term effects, whether it's myocarditis or potentially, worsening of cardiovascular risk factors as well as pre-existing atherosclerosis. And we need to look systematically at these patients now. And this is just one example of, one of the fields that really require a lot of attention and prioritization in the field of cardiovascular medicine.
I think one of the biggest observations that I would make, and I think this is shared by lots of people, is, we have these sophisticated techniques, whether it be, MRI or PET or, even advanced echo imaging, couple that with all these various biomarkers that are out there. But when you look at, for example, the guidelines that came out last year, and they recommend this rather daunting series of serial testing, how do we adhere, at least in spirit, to the guideline, but also keeping in mind what's practically reasonable at any location. So not every place does high level echo or certainly even MRI. And, so if you have a guideline that talks about advanced imaging and you're in a practice situation where that's not even available, how do we marry those two pieces?
Absolutely. And as much of the guidelines were level of evidence C, and also the other thing about value-based care and cost-effective strategies, something that we still need to understand where these tests really lie in the pantheon of, practicality and feasibility, And I think that we, as Dr. Lenahan mentioned, we have to make it a pragmatic approach. And I can say, at least from my own personal experience, dealing with some of these cardiotoxicities, despite all the guidelines and all the science and things, it still ends up being just, these are great, tests to help your clinical suspicion of something, your acumen. It's not like a formula. Nothing is formulaic about it. There's no BNP plus troponin I or troponin T plus a CT equals this. You have to look at the patient, as a whole, and kind of really know kind of what your likelihood of, if there is an issue that could be life-threatening to the patient, especially if it comes to something like immune checkpoint, so.
Yeah, I think that your comment is really important, especially when you say, okay, now we have all these troponin assays that are so sensitive that they'll detect if you sneezed a month ago. I think that the problem is that any test, whether you talk about a troponin, NT-proBNP, or advanced MRI imaging, it doesn't tell you how to be a doctor. You still have to be a doctor. It's just a tool to maybe indicate something. And then how you react to that, that is really the next forum in terms of we've got to figure out how do we react to these things appropriately. Did you happen to get to any of those today, or did anybody bring up some of those issues?
I think that, with that session, people did allude to, again, the high, again, a lot of this was based off, the guidelines were based off of expert opinion, and also the economic sort of feasibility and cost effectiveness is something that also remains a big challenge, and not just the United States, like everywhere across the world, right? Because cancer is everywhere, not just where we are. And I think, and it can't be it's not just tertiary, academic centers that, address these issues. And access to care is also a big problem too, right? And I think, as you said, not everyone necessarily has the access to that as well as to cardio-oncology care. And, I'm not going to lead into our debate tomorrow that much. I'm excited for that. But, but I think, again, that is really also an important reflection of how we need to make sure we refine our guidelines to make sure that they are, reproducible in a real world environment. And until we have better evidence, as Dan was alluding to, you treat the patient, you don't treat the number, and I think that's still an important teaching point, I think, for medicine as a whole, But it's exciting to see what we are seeing more and more of what signals, how these things lead to prognostication. But how we identify the right patient to test it, I still think we have a ways to go,
So, Dr. Addison, let's shift to imaging modalities. Especially, it's a point of interest for me is strain imaging. We all know that still, strain imaging hasn't made really that high in guidelines, especially even in non-cancer patients. But we're right now in cardio-oncology, we're trying to find some parameters that guide us with cardiotoxicity and management. What do you think about strain imaging? What do you think we're gonna see in the future? Maybe we'll have a better value, more important value in the next guidelines in the future.
Thank you for that question. The way I see strain at this point is still a little bit unclear. That's really the simplest answer. I think what we learned from Supor and some of the work that Dinesh and many others have led really told us that strain is a nice tool, an important tool to potentially help us not miss disease, but to actually serve as a true gatekeeper, the best gatekeeper, there's still a lot of question. And really that only relates to anthracycline. We don't fully know how it's going to really play out with a number of the other more novel therapies. Within other disease states, our data with strain primarily relates to patients who already have known cardiotoxicity or suspected cardiotoxicity. So how will this really impact screening? That still remains an open question. I think in the future, what's really going to play out over the remainder of this decade and kind of going forward is that we're likely going to end up with calling it a twofold, kind of a multi-pronged approach in which we combine strain with some sort of either baseline risk assessment or baseline biomarker assessment to actually best determine patients who are likely to go, this is beyond anthracycline, patients who are likely to go on to potentially need interventions or otherwise. I think within the realm of anthracycline cardiotoxicity, strain has demonstrated, at least I think, some reasonable baseline value, especially in resource-limited settings. If you don't have anything else, you at least know that the strain is abnormal and something may happen. And that's an important marker. But I think really how do we best implement this in a systematic, systems-based kind of wide-scale approach still remains a little bit of an open question with more pragmatic trials that are needed in the future.
The core concern I have about all these investigations, while they're very important, like most things in medicine, when we find these things, it's the thing I want to avoid is clinical reaction creep, right? We don't want these findings to necessarily be a deterrent to getting the life-saving cancer treatments they're getting. These are observational, these are observations on cardiotoxicity, but they're not really necessarily a mandate that there will be disease, there will be life-altering disease, and ultimately it's our attempts to understand the course of cardiotoxicity. But we don't want it to be so overly consequential in which patients don't get the treatments or their care is delayed because of these findings and things. And I think that's something we need to also be, we have to caution ourselves and our college as a field.
Yeah, so you are about to open a big Pandora's box there on that one, but I would say that's like one of my favorite topics. But the real issue there is, and whenever I am discussing this with my hematology or oncology colleagues, I want to emphasize to them that, I'm not trying to stop them from treating cancer. What I'm trying to do is allow them to do a better job, getting rid of the cancer. So in essence, you're on the same team. So it's not, oh, this drug causes some cardiomyopathy problem. That's not so much my concern. Is like, how are we going to manage that so that they can get their best cancer therapy? And that's really the essential point. So it's gone from beyond the whole question of whether there's toxicity. It's like, what are you going to do about it? How are you going to manage that so that patients will, complete whatever their best cancer treatment is? So I think these are super important topics, and it sounds like you guys had a great session today, but that means that there's got to be some good things for tomorrow, right?
No, exactly.
Yeah. All right. Sounds good. Thank you guys so much, and great session. And we'll look forward to hearing more about what's going on with the American Heart Association.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.